with Miami Community Health. We're here to talk to you again about another important health topic. Now we're in February. The year is going fast, and we are in Heart Month. The focus this month is hearts, and we're trying to bring you experts from our community who know about the heart, who take care of our friends and family and our patients, and who will talk to us about hearts. So today we have our cardiologist from Baptist Health, from Baptist Hospital, Marcus St. John, to talk to us about the heart.
Hi, Tony. Thanks for the invitation.
Welcome. So heart disease, very common. We know that heart disease is the #1 killer in the U.S. I read a stat that one person dies every 34 seconds from heart disease, which is impressive. So tell us, what do heart doctors do? What do you do?
That's a great question, Tony. Heart disease, as you just mentioned, is the most common cause of death in men and women. So heart doctors do a number of things. We focus a lot on prevention. How do we prevent heart disease? We educate patients about risk factors for heart disease. We help patients understand what their symptoms of heart disease are and when to get screened and tested for it. And then for those who develop overt signs and symptoms of heart disease, who have a heart attack, who have a stroke, we treat those patients and help reduce the risk of recurrence and help get them back to a healthy, productive life.
So despite the fact that it's so popular or so prevalent in our community, why do we have to have a month to focus on it? Why do we have to have the Heart Month?
I think it's always good to have an opportunity to level set and remind patients, and we're all patients, on the steps that they can take to keep their heart healthy. And it never ceases to amaze me as a cardiologist that there are many things that people don't understand or realize that's impacting their health that we may take for granted. So I think having the opportunity, especially early in the year, people are still high off of New Year's and still in the resolution mode, to reinvigorate their interest in heart disease and how to keep themselves healthy. And most things that are good for the heart are just good for health in general.
Okay. Yeah, and then I'm gonna tell you that probably what you're gonna tell me is what I've heard about cancer and lung cancer and skin cancer and everything else. But let's go through that. So we mentioned heart disease, and I've mentioned it, you've mentioned it.
Yeah.
What is heart disease exactly?
So heart disease, when we talk about the heart is a muscle that sits in the chest. For most of us, it's in the left side of the chest, not uniformly. As with all muscles, it has a blood supply, a circulation. So most commonly, when we're talking about heart disease, we're talking about when narrowings or blockages develop in the blood supply to the heart that can cause a heart attack. But there are a lot of other facets to the heart. The heart has valves, the heart has a lining, the heart has an electrical conduction system. So those are all of the elements that go into heart disease. But when we talk about cardiovascular disease in general, then we get into things outside of the heart, but that involve the blood vessels to other parts of the body. So we're really interested also in stroke, and we're interested in peripheral arterial disease, blockages in the neck arteries and the leg arteries, because all of these things impact all of the body. So that is a broad brush, sort of quick overview of what we mean when we talk about heart disease.
So are there, in those heart conditions, is there one of those or two of those heart conditions that affect most Americans, or is the biggest killer for most Americans?
Probably it still is coronary artery disease. And when we say heart disease, most commonly the cardiologist is thinking about coronary artery disease, and then that leads to risk factors for heart attacks. But definitely a lot of atrial fibrillation, irregular heart rhythms, stroke, and high blood pressure is a very common sort of factor that leads to both of those types of problems.
And when you talk about coronary artery disease, you're going to explain a little bit better than me, but it's the blockage of the arteries that are supplying the heart, right?
Correct.
All right.
Correct.
So let's talk about risk factors. Who gets coronary artery disease? Only old people? Only smokers? Talk to us about that.
Tony, you've mentioned two of the biggest risk factors. So age is one of the biggest risk factors, and we can't change age, but there are a number of other risk factors. And just to take a step back, when I talk about a risk factor is any attribute or feature or characteristic that increases the likelihood of you developing the problem that we're talking about, be it cancer, be it heart disease. So we talk about age, we talk about smoking. These are certainly two big risk factors for heart disease. One of them you can change, one of them you can't. High blood pressure is another very common one. Especially
Which you can change or control.
you can. There's a lot of steps, and we can talk about some of those. Diabetes or blood sugar is another one. High cholesterol is another one. There are some others that are less well known that are becoming more and more studied and talked about. I know you've had Dr. Wali on this program. So poor quality sleep is a risk factor. Being obese, sedentary is a risk factor. All of those types of things. For certain populations, pregnancy-related complications, gestational diabetes, high blood pressure, these can be markers of risk. Autoimmune diseases that increase your inflammation in general. But the big ones that most people know or that most people can impact are the blood pressure, the smoking, the sugar, and the
Obesity too.
obesity. Thank
Obesity
you.
for sure.
Yeah.
Okay. So we want to modify those risk factors. You want to kind of
Absolutely.
control them, the ones you can. You
Absolutely.
can't control
Yeah.
age, though
Yeah.
everybody tries to control
Yeah.
age,
Yeah.
right? You can't control them. But if you're sitting and you're listening to this program,
Yeah.
how do I know if I may have heart disease? I may
Yeah.
have that coronary artery disease lingering. I don't want to have that heart attack.
Right.
I don't want to be, I don't want to have that emergency.
Yeah.
How do we know?
Yeah, so symptoms are going to be your best bet. But before that, I think the most important takeaway I want to leave this show with is that you need to know your numbers. And that these days is much easier to do than it was years ago. So you don't have to go to a doctor. You don't even have to go to Walgreens. Many people can check their blood pressure at home. They can even check their blood sugar. You may need a little more access to get a blood test to check your cholesterol, but knowing your numbers mean knowing your blood pressure, knowing your blood sugar, and knowing your cholesterol. With that information, you can then start to form a sense of your own personal risk in conjunction with a healthcare provider. But for anyone, getting to optimal numbers is your first step to reducing the likelihood of cardiovascular disease, to reducing the likelihood of a heart attack. And we can pivot a little bit to symptoms and signs of heart disease if you want, Tony. So the most typical sign that you're having a problem with the heart muscle, especially a circulation problem, is chest pain or shortness of breath. Very often, these symptoms are worse with exertion. Other symptoms that are a little bit less specific to the heart, but very common with the heart, are just exertional fatigue, exertional tiredness. I get that a lot in my older patients. They may not always have the classic, doc, there's an elephant on my chest, but it's always, I just feel tired walking up the stairs in a way that I didn't used to before. Swelling in the legs can also be a sign of heart disease, although can very commonly just be from poor circulation in the legs and other factors. So chest pain and shortness of breath are the big ones. Associated symptoms, nausea, vomiting, sweatiness, can also be signs of a heart attack. So you have to pay attention to those symptoms and get yourself evaluated if you're having those types of symptoms.
So pay attention to your body, make sure that you're not having those symptoms and so forth. So let's say I don't have those symptoms.
Correct.
I've gone to my doctor and he's checking my blood sugar. My blood sugar's good. He checks my cholesterol. It's okay. And I know that cholesterol is a little more complicated. I've learned that's a little more complicated in the old days when I went to school. It was just cholesterol and LDL. There's a bunch of stuff. We're not going to get into that because I wouldn't even begin to understand it. But and then my blood sugar. But then there's tests, like for instance, me, I was sent for a calcium test, right?
Yeah.
And I'm happy to report I got a great number.
Good.
I got the big donut. I got a 0.
Excellent.
So that was great. So that means that, so let's talk to us about those tests, like a calcium score, which is very, very common.
Yeah.
And then the other tests that they do, like I guess they put people through stress tests and stuff like that. Let's go through a little bit of the testing for the heart.
Perfect. So the first sort of order of testing is just the basics, which we talked about. Having a conversation with a physician or a provider just to understand your risk. So other parts of the risk that I didn't mention were family history as well. We also use a lot of tools that help us form a sense of the overall risk of the person in front of us. So let's say you came into the office, we'd say, well, your blood pressure is this, your blood sugar is this, your LDL is this. Oh, look, you fall into a low-risk category, or look, your risk is intermediate. The point of discussing that is if you have very high risk, then you already are someone who will probably just need to be on medications and maybe get some additional testing. Certainly an EKG is a very basic first step, but maybe a stress test. For the patients at low or intermediate risk, where we're not really sure, is this someone that we need to push intensely with their risk factor changes or put them on medicine, the calcium score has become a very useful tool in the decision-making process. So it really is a tool that A, helps you understand at an individual level what your burden of coronary disease is. Do you have plaque or not in your heart arteries, or calcified plaque to be specific? But as a physician, it helps you decide or helps you recommend to the patient in front of you, are you more likely to get benefit from being on statin therapy, cholesterol lowering, or do we not have enough evidence that you will benefit from that? So a little bit of a long-winded answer, but the calcium score helps figure out, are you someone that we need to treat aggressively, or are you someone who is at such low risk that keep working on the lifestyle factors, but you don't need medications? But I do want to suggest that not everyone needs a calcium score. There are guidelines as to who best to get it. No sense doing it when you're too young, and then sometimes we avoid doing it when people are over the age of 75 or 80. But that 40 to 75 age range in medium risk or with certain risk factors may get benefit from a calcium score. If you already have coronary disease, you've had a stent, you already have an abnormal calcium score, you've had heart surgery, you don't need to keep repeating it.
Okay. Well, for clarity, I demanded it.
Good for you.
Because I wanted to check my heart.
Yeah,
You know,
yeah.
and we're going to talk about it.
Yeah.
Prevention is the best medicine, right?
Yeah, 100%.
So I wanted to make
Yeah.
sure I don't have, heart disease in my family, but I
Good.
wanted to say, hey, let's
Good.
check it.
Good.
So one thing we didn't talk about, men and women, is there a difference?
Yeah, there is a difference.
And we can't change. Well, I don't know. I don't know. But
Heart disease often presents a little bit later in women, usually after menopause, although young women who do get heart disease seem to have a more rocky course. But men present earlier, 40s and 50s. Women present a little bit later, perhaps because of the protective effects of estrogen, 50s and 60s. And then what is much talked about is that the symptoms of a heart attack, for instance, in women can be different. I think it's worth saying, first and foremost, that the most common symptom is chest pain or shortness of breath in both men and women, but women are more likely to have less common symptoms, such as just fatigue or not quite feeling well. And that is part of the reason why they have been under-recognized historically. And the textbooks, certainly perhaps when you and I were in medical school, was always the 70-kilogram male with an elephant on his chest out in the cold weather. I can't remember the name of the textbook, and less likely a woman, So there is mostly common ground between men and women and their risk factors and treatment. So we shouldn't try to parse it too much, but for sure, women may have slightly less typical symptoms. Again, that's a male-centric view that all practitioners need to be aware of. And women should be encouraged not to ignore their symptoms in the midst of doing everything else in their busy lives.
all right, so we're here to educate. We're here to talk about heart. We're here to talk about heart disease. We don't want anybody to have heart disease.
Correct.
You obviously see your primary physician. You start with your primary physician. Check your BMI, make sure you're not obese, smoking, your cholesterol, your blood pressure, your blood sugar. Okay, and your doctor checks all that, and that checks out fine. Who needs to see someone like you, like a cardiologist?
If your doctor has checked out all that, it all checks out fine, you're not having any symptoms that are of concern, you really are at low risk for heart disease, and you should keep doing all of the above and check in with your doctor usually once a year by a certain age with an annual check of your numbers for sure, your cholesterol, your blood sugar. These days, it's easy to check your blood pressure more frequently than once a year. And I generally encourage my patients, once or twice a month. If your blood pressure is normal, you don't need to get too crazy doing it every day. But people should get very comfortable just knowing their numbers. We see a lot of patients who end up at the cardiologist or worse yet, in the emergency department, who don't have any health problems because they haven't seen a doctor in 20 years. So that lack of information, lack of knowledge is not a good strategy, because many of these conditions often will present with their first manifestation as a heart attack, as a stroke, as kidney failure. So to answer your question, the low-risk patient with well-controlled risk factors, with a heart-healthy lifestyle, and no symptoms, doesn't need to see a cardiologist.
And who needs to see the cardiologist?
So folks who have risk factors, folks who have symptoms that are of concern, chest discomfort, trouble breathing, folks who have a strong family history, maybe someone has demanded and gotten a calcium score and it's abnormal. So those are the types of people. So most patients who have diabetes, high blood pressure, high cholesterol, even well-controlled ones, at some point in their journey should get an evaluation with a cardiologist just to properly assess their risk and make sure that the medications are optimal and the risk factor control is ideal. And then, of course, anyone with concerning symptoms would then need some additional testing. Very commonly, a calcium score is one, although that's not so much for testing for symptoms, but for screening for asymptomatic patients. But a stress test, oftentimes an echocardiogram, those are the types of testing that we do most commonly. These days, we also have an additional test called a coronary CT angiogram, which can start to give you pictures of the heart arteries, much in the way that you might get with a heart catheterization.
So yeah, for educational purposes, let's go through some of the testing
Yeah.
that is common in
Yeah.
the cardiology world. And you mentioned stress tests, echo.
Yeah.
Well, so explain I actually went through a stress test. I was once airlifted from Haiti on a missionary trip with chest pain.
Gracious. Yeah.
Ended up being some bad food. But
Yeah.
I went through a stress test. So I was on a treadmill stress test. So explain to our viewers, what is a stress test?
So a stress test is a way of causing stress on the heart. By stress, we really want to increase the heart rate to see when at higher levels of demand, when the heart has to work harder, do you develop symptoms that suggest there's a narrowing in the heart artery. So it really is a screening tool for any evidence of narrowings in the heart arteries that might then warrant further evaluation. There are a number of different stress tests. The optimal kind, if you can walk safely on a treadmill, is an exercise treadmill stress test. And I say it's optimal because it also gives us a sense of your functional capacity. Well, can you walk easily for 5 minutes or 6 minutes or 10 minutes? And all those things also have prognostic implications. They matter. So the fitter you are, the better for your overall health and the lower your cardiovascular risk. People who cannot walk on a treadmill or who are unlikely to be able to do very well on a treadmill because of orthopedic issues, because they're just so out of shape, because of bad lung disease, can have a different type of test called a pharmacologic stress test, usually with a medicine that we inject through a vein in the arm, and that simulates the effect of exercise on the body. For those types of tests and for some types of exercise stress tests, we then do additional imaging. Most commonly these days still, it's a nuclear stress test where a radioisotope, basically some nuclear material is injected into the bloodstream, and it travels in the body where the blood goes. And we can get good pictures of the heart that we compare at rest and post-stress. So if there's a big difference with the images after stress, that is often a sign that there's a narrowing in an artery to that part of the heart, and that might warrant further investigation. The next very common type of test that we do is the echocardiogram. That's an ultrasound on the heart muscle. And it's a very useful way just to get a global sense of the heart's overall health. Is the heart squeezing well? Is it relaxing well? Do the valves open well? Do they close normally? And that's something that we do very commonly. It really is a bread and butter part of a standard cardiovascular evaluation. Not everyone needs to have one. Again, guided by what are the questions you were trying to answer, but a very common part of the evaluation. And then I mentioned briefly the coronary CT angiogram, which is a type of CT scan, still done most commonly in the hospitalized patient who is presenting with acute chest pain, and is a very quick way to rule out a serious blockage as the cause. Again, very clear guidelines as to who should get that, that we don't need to go into here. That's less common in the outpatient setting, but becoming more common because it can be a way to avoid invasive testing, to really check for narrowings in the heart arteries when someone has concerning symptoms or an abnormal stress test.
And then I know that once you end up with a positive stress test and you have an abnormal, if you came to the ER with chest pain and you have an abnormal stress test, or even if you have EKG changes, you're going to get a cardiac cath, a catheterization. And that, I mean, how many catheterizations do we do a year, like here at Baptist or in the country? I mean, these are millions, right? I mean, this is like a lot.
We do thousands in the country, millions for sure.
Wow,
so it's a very common test, one that, as with all tests, should be done in the appropriate patient. in the appropriate setting.
And the catheterization, I mean, it used to be through the groin.
Yeah.
Now it's in the wrist.
Yeah.
Explain to us a little bit about what is a catheterization and then what more can be done in there, because I know now you guys are fixing people's hearts through that as well.
So catheterization is an invasive procedure. It is generally less scary than most people think it is. So I'm glad to have the opportunity to talk about it. Very often it's an outpatient procedure. By that I mean you get the test done and you go home the same day, even if you get a stent. So the patient comes in, they haven't eaten usually for 6 to 8 hours, but we usually say nothing to eat after midnight. You'll get an IV because we do give you sedation. It's not general anesthesia, as you may use in some of your patients, Tony, but it's what we call moderate sedation. It's light enough that you are pleasantly sedated, but you're breathing on your own. As you mentioned, we usually go in these days through the wrist artery, but the groin artery, the leg artery, is still a very attractive option, especially if the route from the arm to the heart is a little bit windy or the arteries are a little bit too small. From either route, we get to the heart, we inject X-ray dye, we take pictures of the arteries, and we see if there are narrowings in the heart arteries. For patients who do have a significant blockage that we think is causing symptoms that haven't responded to medicines that we can help by putting a stent in, a metal coil, we usually do that at the same time. When the stent gets deployed, it opens the area of the blockage. Many people have the concept that we are sort of clearing out the narrowing, or roto-rootering is the term I hear a lot. So we're really just squishing the plaque, the cholesterol out of the way, opening the artery, and then that becomes part of the wall of the artery. If what we see in the cath lab is blockages that we can't treat safely with a stent, or in such tricky locations or so many blockages, then the patient may need to be referred for heart surgery. And then what you alluded to is there's a lot of other things that are being done by ever specialized cardiologists, what we call structural cardiology, but really where we're starting to treat heart valve disease with interventional procedures. So things like putting in a new valve in the aortic valve, or reducing leakiness in a valve by putting a clip in it, things that maybe even 10 years ago were the domain entirely of open heart surgery can very often now be done in a minimally invasive fashion.
Wow. And so people do still need open heart surgery, right?
Yes.
All right. And
sure.
And obviously open heart surgery has progressed quite a bit now. Now it's not as, there's a lot of minimally invasive open heart surgery.
Great. I appreciate that comment, because absolutely. So it's not as if heart surgery has stood still while interventional cardiology has progressed, and there's a lot of overlap and synergy. As you know, we have one of the world's experts in minimally invasive surgeries. I think you've interviewed him on the program, Dr. McGinn. So that's very attractive for both cardiologists and patients, that we can refer our patients for complete revascularization, and they never need to have a sternotomy. So the incision is a smaller one through the chest. And there are many other procedures that can be done that way, some aortic valve and mitral valve procedures. And before we leave the topic of procedures, we talked a lot about coronary disease. We certainly talked about valvular disease, but there's also a whole world of electrical heart disease that is very common. Atrial fibrillation is the most common type of arrhythmias, and there are a number of procedures to manage that. And many people with advanced heart disease may need defibrillators and pacemakers. Not so much, I think, the focus of what we're talking about, because the risk factors that we're talking about are more germane to reducing the risk of coronary disease, but there's a lot of overlap. So disordered sleep, breathing, high blood pressure, obesity, these are all factors that are linked to atrial fibrillation. Certainly poorly controlled hypertension is a big factor in development of heart failure and weak heart muscles, and those patients may need defibrillators. So there's a lot of overlap, but much of what we're focusing on is really coronary artery disease, the buildup of blockages in the heart arteries.
Yeah, it's another area completely of the heart that we haven't talked about, and there's a lot out there. Like everybody from, you could check atrial fibrillation on a little thing on your iPhone, and then of course there's all these commercials about blood thinners for atrial fibrillation and so forth. Well, obviously this show is about education and prevention and really empowering our public. And you wanted to talk to us a little bit about, American Heart Association and talking about prevention, because prevention is the best medicine,
Absolutely.
And so talk to us a little bit about that.
So as I mentioned to you, Tony, in the pre-show, the American Heart Association has sort of tried to flip the script and focus less on heart disease, but how do you keep your heart healthy? Until recently, they had Life's Essential 7. Now they've updated that to Life's Essential 8. So the addition, before I talk about the other 7, was the importance of sleep as an important part of heart health. So
we've heard that over and over here and in shows about all conditions, but that's okay, great.
The quality of sleep, the length of sleep, screening for sleep apnea, sleep impacts ability to lose weight, your mood, your energy, your risk for coronary calcifications, your blood pressure. So I think many of us sort of give short shrift to sleep and, well, I'll work later, or I'll get up earlier. I like to tell certainly my friends, if I have the choice between getting up early to exercise or getting sleep, I'll take sleep. But so the other parts of Life's Essential 8, eating better, a wide variety of healthy vegetables and fruits, whole foods, avoiding processed foods. This is really the important thing, avoiding sugar, saturated fats, and salts. Trying to do more of your cooking at home and being mindful of what you're eating. Being more active, that's a very important part of it. The American Heart Association calls for 150 minutes of moderate intensity activity or 75 minutes of vigorous activity a week. Doesn't sound like a lot, but especially when you break it up, and you really can break it up into very small segments. They also remind us to get some weight-bearing exercise throughout the week, at least twice a week. We talked about sleep, quitting tobacco, and it would be remiss of us not to harp on that. So that's a very low-hanging fruit. It's not an easy thing to quit if you've developed that addiction, but lots of treatment options and strategies. So if you smoke, now is the time to stop. Managing your weight, I think we touched on that, but trying to get to a healthy weight. There are lots of ways to get there now, healthy eating, healthy lifestyle, but weight, we're learning, is almost a disease entity unto itself.
It's linked to so many other conditions as well.
You're the expert in that, Tony, at least with one manner of treating that. Controlling cholesterol, we touched on, managing blood sugar, and managing blood pressure. So those are Life's Essential 8. And there's some health factors, and there's some factors that you're just born with. But addressing those, knowing your numbers, that's the way to go. Because as you said, I think at the beginning, prevention is the key. So if you never need to see me, that's a great thing.
Wow. Well, we've learned a lot. Thank you for educating us on Heart Month and the American Heart Association, the Essential 8. And as I always say, obviously keep yourself and your family healthy, and health is obviously something very, very important, something we cannot replace. It's better off seeing Dr. Marcus St. John just by accident because you had some pain in your chest and it was not your heart, as opposed to really seeing him laid up in a gurney in the ER with a heart attack where he's got to rush you to the cath lab. So thank you, Marcus, for coming around. Thank you for educating our population. And once again, Dr. Anthony Gonzalez from Miami Community Health, educating the community about healthy lifestyles, paying awareness to Heart Month now in February. And really, as Dr. St. John said, Life's Essential 8. Control those risk factors is not only going to help your heart, it'll help all other aspects of your body and your health. So once again, from Miami Community Health, be well, take care of yourself and your family. Have a great day.